think we give enough time for people to assemble here. I'll try not to put you to sleep, I promise, but I'll do my best. So we're going to talk about ECMO, essentially the extracorporeal membrane oxygenation. Nowadays, it's called extracorporeal life support. The device, for the most part, has been in use since the early 70s. And the purpose of it is to support the lung or the lung and the heart function for critically ill patients. Historically, the whole invention started as a dream in the 1930s when Dr. John Gibbon was a new grad at Mass General, sitting at night as an intern, had the assignment to take care of a young lady who had massive pulmonary embolus. And he agonized all night. His job was essentially to record her vitals every 15 minutes for the night, and he saw her over the course of the night lose her life gradually. And by 8 a.m., she lost her vitals and she died. So during this agony for him, it was a very emotional situation. And his only thinking was looking at her distended jugular veins. And he was dreaming about the possibility of being able to take that blue blood, siphon it into a machine that can oxygenate it, get rid of the CO2, and return it into her arterial system. And lo and behold, he continued with that dream and moved on for 20 more years after that, between Mass General and working in Philadelphia. Well, only for a brief interruption for the Second World War. For the most part, he was working on producing the machine. Essentially, this is a picture that was taken of him in 1953 when the machine was first used. And you can see how large the device was. This is a heart and lung machine, practically the first prototype. You can see the oxygenator here as a bubble oxygenator, where they used to collect the blood in a big container and just insufflate oxygen in it. And needless to say, that was a very toxic process for the cells. So this machine, despite its magnitude, was good enough to support the patient for only a couple of hours before the toxic effects of the machine led to significant problems. However, with improvement over time, the pumps improved, and membrane oxygenation started coming. The membrane lungs started becoming available. So Donald Hill reported out of the California Pacific Medical Center a very interesting case of a young man, 24-year-old man, who suffered from severe trauma, went into the term of shock lung that was coined in the Vietnam War. He had ARDS practically because of the trauma, and they supported him with V-A ECMO, which the term did not exist at that time, but they used the machine on him for a few days. His ARDS subsided and the patient survived. So that was the very first report in 1972-73 in the New England Journal of Medicine. Motivated by this, essentially, many people started using it for patients coming in with lung failure who are not responding to maximum medical therapy. And by 1974, about 150 patients were treated that way in multiple medical centers, with a survival rate that was quoted anywhere between 10 to 15%. Obviously, the survival rate was very modest, but considering that these patients almost 100% of the time would have died, this was substantial. So there was a multi-center study in 9 major medical centers throughout the United States, sponsored by the NIH. The study essentially was a randomized controlled study looking at lung failure patients who had PO2 of 50 or less on 100% FiO2 and PEEP over 5, coming in with severely disturbed chest x-rays, and were randomized to either ECMO support plus ventilation, or ventilation support in addition to regular medical management with antibiotics and so on. The study design essentially was flawed by the fact that there were no set protocols for ECMO management and so on. So they made some protocols for this study particularly. And in my mind now, looking at it in retrospect, the biggest flaw in the study was essentially that they set the maximum ECMO support at 5 days. So the patients who improved got weaned earlier. Patients who did not improve by 5 days were explanted. And needless to say, they went ahead and found that for the ECMO-supported patients, the survival from the initial insult was superior to patients who were managed only medically. However, time to discharge, only 10% of the patients survived in both arms of the study. So basically, they concluded that it's feasible to support patients with ECMO. However, it does not make any impact on the outcome. So with that, a lot of the early adopters and enthusiasts ran away, which is a recurrent story in medicine. We see it all the time. However, a few brilliant minds, including Dr. Bartlett at the University of Michigan, who was involved with the initial study, maintained their belief in the concept, that it's a valid concept, and they tried. He dedicated his entire life practically with an army of other people. I mean, I can't give him the credit alone, but he was the leader. And many of the people who worked on ECMO were his trainees. He dedicated his entire life to figuring out the kinks and the wrinkles and rectifying it, working with the industry and working in basic science all the time to just figure out why it didn't work as well and try to improve it. And he certainly, with his effort, put it on the map. So first of all, technological improvements in the design, going from the roller pumps, the DeBakey roller pump that was invented in 1932, evolved into axial flow pumps and centrifugal pumps, which are much more friendly for the blood elements and can be used for extended periods of time, days up to months. Became more available. The tubing technology for blood and the surfaces that interacted with the blood became a lot more sophisticated with heparin coating and carmida coating. So a lot less inflammatory response was produced by the machine. So all these technological improvements coupled with better understanding which subset of patients will benefit from this technology, how to select them, when to implement it, and how to manage them, what's the goal of the therapy. All these things were figured out over time and resulted in significant improvement in the outcomes over time. So the technology became, again, more popular and more in use. In general, we have two basic ECMO indications. There is the veno-arterial ECMO, which is essentially a complete bypass of both the heart and the lung, and the veno-venous ECMO, which is a pulmonary support, more so than hemodynamic support, because we still, with the veno-venous configuration, we still depend on the patient's own heart to get the blood to the left side and get the blood from the left ventricle to the system, as opposed with the veno-arterial takes over both organs, similar to the heart and lung machine. The device itself has multiple components. I'm not going to bore you with the technical aspects, but just for the sake of the discussion, you have the cannulae that siphon the blood out of the patient's heart. Here, this pointer is not working that well. You have a cannula in the right atrium here. This is central cannulation model. It takes the venous blood down. There is a reservoir that we don't have in our current devices any longer, but it brings the blood down to a pump. The pump pushes the blood into the oxygenator, and it gets oxygenated, so blue blood exits as red blood, and it goes back to the patient's aorta. The oxygenator is connected, in addition to the blood, it's connected to a gas mixer or blender, which will provide most of the time 100% oxygen, or sometimes we mix 95% oxygen with 5% CO2. There are multiple things that go with this. There is a flow probe that monitors the flow from the ECMO all the time on these things. There is also a bubble detector to make sure there is no air in the system. Once it's detected, it will shut it off. And then we have multiple pressure monitors. There is a pressure monitor on the venous side before the pump. There is a post-pump pre-membrane pressure monitor with saturation monitor, gives you the mixed venous blood saturation. And after the membrane, there is also a pressure monitor afterwards and a saturation monitor. These are just the devices to help us micromanage the situation and detect any flaws in the system early on so we can fix them before it becomes a disaster. So this is the basic cart that we've been using up until recently. It's a fairly bulky device, and all the major components I showed you on the cartoon practically are here. The oxygenator, the pump, the heater an extra battery that supports it in case there is electricity problems, then the battery would support the ECMO for about an hour or two. A hand pump, and in addition to this, you have the console for controlling the pump and the monitoring screen that gives you different pressures and so on, in addition to the mixer with the blender for the oxygen devices. Technology evolved, and recently we adopted this device called CardioHelp. It's a very portable device, practically it's only this big. It provides a lot of flexibility in terms of portability and safety for patient transfer, and allows for transfer between institutions. But in addition to this, with the compact technology here, the oxygenator is hooked up directly to the pump, and this connection here provides a very wide inflow for the blood, which actually, the advantage I'm noticing using it over the last couple of months, it reduced the area where there is stasis in the blood, and I'm using this configuration for the last 4 or 5 ECMOs. I did not see a single clot in the system, so I think there is an advantage from a technical standpoint. Also, the beauty of this pump, the pump is in there, the controllers are here, and this screen will give you all these pressures and saturation monitors all built in the system in a very compact unit. So recently we switched to using this device for us. In general, in a simplistic way, who should have ECMO? In a very simple way, people who have heart or heart-lung or lung failure that's not responding to standard medical therapy or maximum medical therapy. So that's in a simplistic way looking at it. Referring to the Extracorporeal Life Support Organization guidelines, the basic guideline, they stated that using any of the calculators, whether the Apache score or the Murray score, any of the calculators that we use normally in the ICU to predict mortality, if the prediction of mortality is over 50% with maximum medical management, then ECMO should really be considered seriously. If it goes over 80%, then ECMO is indicated, unless there is a clear contraindication to the application of ECMO. So that's kind of a broad brush. But now looking at more specific indications for the veno-arterial ECMO indication, it's usually indicated for patients who present with severe cardiogenic shock, unresponsive to the standard interventions. This could be a massive myocardial infarction, a case of viral myocarditis, postpartum myocarditis, or cardiomyopathy, I'm sorry, or situations where you have patients who have heart failure that's standing there for a long time and present with acute exacerbation. These patients present crashing and burning, and sometimes whatever you do medically is not good enough for them. So if they have indications for the second level of therapy, they should be stabilized with something similar to ECMO. The other indication for veno-arterial ECMO, which is becoming a little bit more popular and gaining more vogue, is the emergency department application of ECMO during witnessed CPR. Obviously, this indication could be somewhat of a vague indication, but in general, if you have, relatively speaking, a patient who's not too old, a patient who does not have a condition that's not compatible with survival later on, and the CPR is not good enough, but it's a witness episode and CPR is producing reasonable perfusion and you can't get the patient out of this pickle, then application of ECMO in the ER is a reasonable approach. Although in my mind, this is probably the most difficult setting where to insert ECMO in. The patients who present to us, we see it in this area in the winter, where we have these poor homeless people who sit out there and get frozen with severe hypothermia. This is probably the most effective device to rewarm them and see if we can salvage their life. And recently there is more application for organ retrieval. I'm not going to delve into that. It's a total different animal here. For absolute contraindications for the application of veno-arterial ECMO is for patients who are not candidates for either VAD or transplant in the future and have an irreparable cardiac damage, like massive MI or something of this nature. Another contraindication is prolonged CPR if things go beyond normal limits, or CPR was not witnessed, or during the CPR we're not able to perfuse the body, attain reasonable pulse pressures and so on, then it's probably a moot point to try to waste resources on that. Also, an absolute contraindication is patients who present to us with entities like stage 4 cancer or advanced systemic illnesses that are not compatible with normal survival, or patients who have cognitive and psych issues also, which is, again, that's kind of a tough one to figure out in an emergency situation. But if it's known somebody has an issue with compliance and cognitive issues, probably you should not be venturing into this type of technology. The other category of ECMO application is veno-venous ECMO, which is essentially an indication for lung salvage or lung patient salvage. The number one indication is hypoxemic failure. When you have patients presenting with severe hypoxia that's not responding to the standard medical management, and they have an estimated mortality of 50% based on PaO2 FiO2 ratio of less than 150 or 90% and P up to 10, or a Murray score, and I'll tell you a little bit about the Murray score in a minute, but a Murray score between 2 to 3, then they have an indication to proceed. And the indication is really clear if it's 80% mortality estimated on someone who's reasonably salvageable otherwise. The other indication also, we can implement ECMO, even people who are able to oxygenate reasonably well, but they have very severe CO2 retention that we can't control with a PO2 of over 70 and a pH of less than 7.15, despite all management and ventilator adjustments, especially if the plateau pressures are over 30, 35, then it's reasonable to consider ECMO for CO2 removal. The other condition is when you get people with massive air leaks and you can't control air leak with positive pressure ventilation, then they can be controlled with ECMO to minimize the positive pressure ventilation on them. Patients who are on the transplant list with certain conditions who present with need for intubation. For the most part, if you have someone with COPD or bronchiectasis or cystic fibrosis, we can intubate these folks and trach them and maintain them on the vent until they get a transplant. But there are conditions like IPF, you know, and we know from experience that once they need intubation, it's very hard to ventilate these patients. And sometimes they end up losing their life or end up needing very advanced level of paralytics and so on, which will interfere with the outcome from transplant. That subset of patients, it's very reasonable to consider veno-venous ECMO application for it. And more studies are showing, series actually, not studies, showing evidence that there is value in that concept. And then immediate collapse, things belonging to loss of airway that's not retrievable with medical intervention. PE, maybe veno-venous, maybe veno-arterial, more reasonable than any other things. But these emergency situations, a trauma case where disruption of the trachea or something of this nature could be managed with temporary veno-venous ECMO support. Again, the contraindications, there are a couple, all the contraindications where veno-venous are really relative. And it depends on, we have to consider each patient separately. But in general, the data from the H1N1 trial and before it taught us that patients who are on high vent settings, FiO2 more than 90%, PEEP in the 10 range, for more than 7 days, when they go on veno-venous ECMO and they were on support for more than 7 days, their outcome is not as good as patients who were on the support for less than 7 days. So that's a relative contraindication, but again, if you have a very young patient coming from an outside institution, you're probably going to give them a chance. But survival goes from 60 to 80% if they were on the ventilator less than 7 days. It drops to 30% when they're on the ventilator for 7 days or more. So that should be considered. Patients who are on immunosuppression, as you might imagine, it complicates their management. Folks with brain bleeds, especially a recent one, expanding brain bleed should not be considered because they have a contraindication for anticoagulation. But even this is a relative contraindication because in this day and age, with the coated circuits that we have, we can really apply veno-venous ECMO without anticoagulation, at least for a few days, in a relatively speaking safe way. And then patients who have comorbidities that are not amenable to recovery, like if someone has completely destroyed lung or something of this nature, and you're not going to be able to bridge them to transplant or anything meaningful, you should not proceed with this. And then age, which is another huge gray zone. But I think if you get an 80-some-year-old, you probably don't want to do that. Looking at the Murray score was published in 1988, and it's geared at assessment of survivability of patients with ARDS. It has 4 main categories. Essentially, the X-ray appearance, number of quadrants involved with the infiltrate, and then the PaO2 FiO2 ratio, the amount of PEEP, and then the calculation of lung compliance. In general, a score from each category is taken, and they're added up and divided by the number of categories that was applied to. So the average is taken. And if you have an average Murray score that's between 2 and 3, usually estimated mortality from ARDS is 50% in the best of scenarios. If the added score, the average score is 3 to 4, then the mortality is 80%. I think it serves as a good tool. Now, what do we have in terms of cannulation options? So we'll start talking about the veno-venous ECMO. In an ideal world, in a patient who's relatively speaking not crashing and burning and dying, you want to apply a single cannula if you can. You want to apply it in the neck. And that requires a trip to the operating room. And in my hands, at least, I use the transesophageal echo and fluoroscopy together to be able to place this cannula in a good position. So this is the Avalon cannula that has two channels, practically, one for drainage, and the other channel is for inflow of blood into the patient. So the inflow, this is the inflow arm, and it comes out over here. And then there's a channel here and a channel at the tip that sucks the venous blood out. So the way we position this cannula, essentially the tip of the cannula will be in the IVC just below the diaphragm. And then the upper chamber, the upper drainage hole will be in the superior vena cava. This thing should be positioned in the right atrium opposing to the tricuspid valve. So when the blood comes back from the ECMO machine, it should blow directly into the tricuspid valve to go into the right ventricle. And then we're going to depend on the patient's own ventricle to push the blood through the lung down to the other side. So that's one cannulation technique. The other cannulation technique that comes in very handy if the patient is very, very sick and you cannot move them anywhere. What we do is essentially we cannulate both groins. We use the femoral veins on both sides. One cannula is placed into the IVC. This is for drainage. The other cannula is advanced all the way up to the level of the atrium to bring the blood back. In the last few cases that I've done emergently, I used a dual-stage cannula for drainage that goes from the right groin all the way to the superior vena cava. And it has 2 stages to it. One stage in the superior vena cava, the other one is in the inferior vena cava, well below the diaphragm. And that drains the blood from both veins, and I put the blood back into the right atrium through a different cannula in there. With that type of drainage, it provides me with the best saturation I can get for the most part. And again, be careful with this approach, because if the patient has significant hemodynamic compromise on the basis of cardiac issues, you probably don't want to depend on the RV alone for support. You want to do V-A ECMO instead of V-V ECMO. So that has to be distinguished up front.
Can I ask you, does that mean that the flow from the upper area in the head, that's going to be unoxygenated blood, is going to go back to the heart?
Yes, some mixing happens on the right side. But with the mixing, I'll touch on this a little later. But with the mixing, it should provide you with a saturation well over 80%. So it should be sufficient. The other options for cannulation, in addition to the femoral veins, is femoral vein, femoral artery for the VA ECMO, or central cannulation, where post-cardiotomy syndrome, when patients cannot come off the heart and lung machine, we have access to the chest, so we can put the cannula in the aorta and the right atrium. Another option also is drainage of the veins from the neck with that Avalon catheter coming back into the axillary artery on the right side. And this, even with veno-arterial ECMO, will allow the patient to be extubated and walk around and ambulate and so on. Yeah. When it comes to management now, essentially there are several categories, and I'm not going to go through the whole details because that could be a subject of a grand rounding by itself. But for anticoagulation, there are several phases for consideration. Initially, during the initial cannulation, we need aggressive anticoagulation approach because we don't want any clots forming in the cannula while we're doing the cannulation. In general, personally, I resort to a full heparinization situation in the patients, which produces ACT about 400. On average, we give close to 300 units per kilogram of heparin IV bolus. Obviously, if you have someone with post-trauma, you don't want to go that stupid because you might kill the patient. So you have to kind of look at it. I mean, none of the stuff we're saying is they're guidelines. They're not God's word. You know, so they can be violated. But each case has to be looked at individually. But in general, if we have the option, we want to fully heparinize the patient during cannulation. Once we're done with that phase, now we'll go to the maintenance phase. In general, we look at PTT about 1.5 to 2 times normal. Or if we're using ACT, we don't use ACT here a lot. We use it only in the OR, but it's not available to us at the bedside. If we're using ACT, the usual guideline is to go between 180 to 200 for the ACT. And that's usually good enough for maintenance. When the time comes for weaning, especially with the veno-arterial ECMO, we normally wean the veno-arterial ECMO by coming down on the flow. So once you bring the flow to about 2 liters or less, you have to intensify your anticoagulation because there is a risk of formation of clot in the pump. So you don't want to go there. When we're weaning, we have to be careful that we have to shoot up at ACT maybe 300 instead of 180 to 200, or intensify your PTT to get to the high protocol range, in the 100 range, just to prevent clot formation in the pump itself. A lot of issues happen with these patients with HIT and so on. In general, the alternative therapy, if we're not going to be able to use heparin, the only other agent that I've used safely here was argatroban. In different practice, I've used argatroban and I used bivalirudin too. They both are usable, but we have to adjust based on these agents. In terms of management of the flow, that gets back to your question, actually. The purpose of the ECMO essentially is to support the saturation for the V-V ECMO, to support the blood. So if you have only a cannula in the IVC and a cannula bringing the blood back into the atrium, then there is a lot of mixing of blood that's happening in the right atrium because blood coming from the SVC is hypoxemic and mixing with our product. In general, when we use flow, we look at flow of about 2 to 3 liters per centimeter per meter square of body surface area. That's about an index of 2 to 3. With that kind of flow, if you have a functioning oxygenator, which I hope you do, essentially you're going to get a blood saturation in the atrium of about 80 to 85. So whatever the lung contributes to that, systemic saturation with veno-venous above 80 is perfectly acceptable. And patients do well. I know a lot of folks here panic and just like, oh no, we can't do this, and he's sat in only 85%. Well, 85% is very good for veno-venous ECMO. Granted that you're maintaining good perfusion pressures, maintaining good hematocrit to make sure oxygen delivery to the body is there, and make sure the perfusion status of the patient is adequate. So they're not acidotic, they have good urine output, they have good perfusion, and so on. But if that becomes an issue and you're not able with the mixing to saturate, then adding an SVC drainage to the venous side will improve on the situation. The thing that I discourage people from doing, but I can't get my guys in the ICU to comply with this, essentially is to avoid going up on the ventilator when you don't like the SAT. You have the ECMO for that purpose. The whole concept, we need to rest the lung. We don't want to stress the lung out during this process. We're not dependent on the lung. So for veno-venous ECMO, using the catheter I showed you, the Avalon catheter, has the beauty, it drains both the SVC and the IVC. And with a decent amount of flow, usually you're able to get the saturation, for the most cases that I've been dealing with, well over 90%. So which should work well for us. When we look at veno-arterial ECMO, the indication is different because you're not just supporting the lung, but you're supporting the heart also. In general, the saturations with that, again, the same flow, practically an index of 2 to 3. We try to bring the flow down to the least amount possible because high flow usually puts a lot of trauma on the blood elements inside the pump. So we like to get the least amount of flow that gives us the result we want. We want good perfusion pressure. We want good urine output. We want evidence of excellent oxygenation. So we have to monitor all these things. And the most sensitive thing that I find the most helpful parameter to watch for on veno-arterial ECMO is the mixed venous saturation. If you get mixed venous saturation of 70% and above, rest assured that you are perfusing this patient well and you're supporting the patient well. Obviously, what goes into this is how much oxygen you're putting, the flow, the hemoglobin level, all these things we have to manipulate, volume status, we have to manipulate things just to achieve these goals. If we're using the ECMO only for CO2 removal, then flow of about quarter of the normal cardiac index is good enough. And in general, that's sufficient to get the CO2, the desired amount of CO2 with that. So obviously, we don't do a lot of that, just ECMO for CO2 removal. But there is a device, and it's actually, this ECMO is not V-V, it's aortic or arterial venous, it's reverse. It uses the arterial pressure to drive the blood into the pump to remove the oxygen and bring it back into the venous system. And that doesn't need a lot of flow. Usually flow of 1 liter per minute is good enough to support it. What do we do with the ventilator? Once we have ECMO established and we're happy with the flow, the whole concept is to rest the lung, essentially put it on resting settings. So we minimize the oxygen to about FiO2 of 40% or even less. We try to get down on the airway pressure to reduce the barotrauma. So I like to aim at a plateau pressure about 25 or less. I put the tidal volume accordingly. And I usually put the PEEP about 10. That's my personal choice. Anywhere between 5 and 15 is good. And then usually the rate about 5 or 6 per minute. You don't need more than that. The whole idea is just to keep the lungs gently inflated without any extra barotrauma or oxygen toxicity on them to allow them to heal. And this is a very nice thing to look at because on a daily basis, when you come and see these patients as they improve, you start noticing that your lung compliance is improving because with the same plateau pressures, you start seeing a lot higher tidal volumes. And that's usually a sign that the lung is improving. At that point in time, we may want to get a little bit more aggressive with the volumes just to enhance the recruitment of the alveoli and prevent atelectasis. But for the most part, the lung should be rested with these settings. In terms of blood work, usually the protocol that's recommended, we need frequent blood gases in the beginning. We're going to need to check them every couple hours until we get to a reasonable steady state. And then we can use the saturation monitors on the ECMO machine itself and on the monitors for the patient to guide us with the therapy. But initially, I do blood gases every 2 hours to make sure I don't have rising acidosis situation, make sure I'm oxygenating the patient well and getting rid of the CO2 in a reasonable way. Then we can, after the first day or so, we can probably cut it down to once or twice a day. Looking at the coagulation factors, as you well know, this is a very intense intervention. So there is a component of biology versus machine interaction. So a lot of our patients get coagulopathic. A lot of our patients have platelets absorb on the system and drop their platelets. And a lot of times also we traumatize the red cells and we have drop in hemoglobin levels. So we have to monitor all these things. In general, I look at these things every 6 hours, at least in the first couple of days, until I get to the steady state. And there were multiple guidelines. People say you should never let the hemoglobin drift below 10. Other people say the platelets have to stay at 100,000. Well, in general, in adults, at least over the last 14 years I've been using ECMO, I usually set my hemoglobin level to 8. And I've done okay with that. Platelets, I don't like to transfuse platelets because in my mind, I've seen a lot of lung injury from platelet transfusion. So I would hate to bring a patient with an already injured lung and give them another thing. So I tolerate platelet count at 20,000 as long as the patient is not showing signs of active bleeding. And then the other thing that we need to monitor also is the fibrinogen levels. In general, I like to keep the fibrinogen levels about 200. I replace them with either cryoprecipitate or fresh frozen plasma. I prefer cryo because of the higher concentration. So all these blood tests can be minimized after the steady state is reached over a day or two. But in general, I like still to continue checking the hemoglobin between 6 to 12 hours at least once, and move on with that as the patient goes. A lot of these folks, especially the septic patients, when they come to us, they have significant need for fluid boluses. And when we go on the ECMO machine, we dilute their hematocrit quite a bit because the ECMO routinely is, for adults at least, not for pediatrics, but for adults, is primed with isotonic fluid. So that's gonna dilute them and give them a lot of fluid. So they tend to develop edema, they tend to develop capillary leak syndrome. You're gonna have third spacing. So you have to manage it accordingly. Make sure that the volume status is adequate inside the vessels, otherwise the ECMO is not gonna flow. Once you get over the acute inflammatory phase, you start noticing these patients' central venous pressure starts going up. You need to enhance their diuresis. Whether their kidneys are working, then simple diuretic measures are good. If the kidneys are not working, I'm very aggressive implementing CVVHD or some form of dialysis involvement early on in the process.
If you over-diurese the patient, would the flow get affected?
Yes, you'll see it right away, because what will happen, the venous drainage starts going low, and you start seeing the venous line shattering. That shatter is something to avoid, because when you measure the pressure on the venous line, you'll see it coming to about -300. You don't want to reach that. You want to keep it anywhere between 200 and 300. You don't want to go any lower than 300. Because if it goes, then you start damaging the blood elements. And also, if there is any potential for air leak in the system, that will suck air in the system and cause a disaster. So yes, you have to be careful. Always balance these things. When you're diuresing the patient, you have to keep an eye on the flow and the volume status. Be careful with it. But also it's a must, because many of these patients, especially the heart failure patients, in order to improve the lungs, you have to reduce the fluid. So over the course of a couple of days, usually you're able to do that. And then the rest of the management is just basic intensive care issues, whether antibiotics, nutrition, all the stuff that we do routinely for our patients. Positioning, mobility is very important. These patients should not be left alone. I mean, early on when I started doing it here, people would not even touch the ECMO patient because out of fear of dislodging the cannula and stuff like this. Well, yes, we need to be very careful with the cannula because that's a disaster if it happens. But we can't allow these patients to have position-induced atelectasis or pressure sores and stuff, because that's going to interfere with their healing process. So mobility is important. And a lot of times I'm a big advocate for extubating the patients, if possible, to get them a little bit more mobile. Obviously, they're not going to sit in a chair, but get them somewhat mobile to protect them. Complications are many. The technology, this is a treatment modality that's fraught with a lot of complications. And what I learned, the only way to get successful with these things is to stay very vigilant, detect them early, and take care of them right away. If something happened at midnight, don't say you're going to come back at 7 a.m. and take care of it, because odds are you're going to have a dead patient by then. So complications are very important to manage immediately. Bleeding is very common from the cannulation sites in particular, but all sorts of bleeding could happen: brain, GI tract, and so on. Thrombosis, invariably these circuits will have some thrombi forming in the circuit over the course of a day or 2 or 3. Most of these thrombi are just small fibrin clots, less than 5 millimeters. I see them mostly on the venous side, usually at connection sites. We see some clots in the oxygenators forming. As long as they're less than 5 millimeters, we keep on watching. Actually, what's going to take to detect that is every 2 hours, checked by the nurses with a flashlight going over the entire circuit from top to bottom, looking at everything and reporting any enlargement. Again, using the CardioHelp device, for the last 5 or 6 patients, I did not see any clots in the system. We used it once for about 3 weeks. When we explanted the patient, I dumped everything out, and the circuit was entirely clean. So I hope it has an advancement from that standpoint. Hemolysis, we see some hemolysis. The pumps are more friendly nowadays, but if there is any thrombus formation inside the pump, then you start hemolyzing. Hemolysis happens also if you have very, very high negative pressure on the venous side, or if the cannula into the arterial side is very small, leading to very high velocity, or kinks in the lines, that could produce hemolysis. So if the plasma-free hemoglobin level is more than 10 milligrams per deciliter, you have to look into these possibilities, especially a thrombus formation in the pump or the oxygenator, and take care of that when needed. Limb ischemia, we see it with peripheral cannulation. And we have a few tricks that we use to get over it. The most drastic one is ischemia of the legs when we do percutaneous femoral cannulation. We get away with that essentially by putting a smaller cannula in the superior femoral artery and perfuse distally with a smaller cannula to keep the limb. The other complication I've seen when I do axillary artery arterial cannulation, sometimes you see massive swelling of the arm, so it's important to do some banding on the artery beyond the cannula to lower the amount of flow coming to the limb, and that usually takes care of the issue. Couple of things that are important for folks who are at the bedside watching this ECMO. Something called recirculation. This is peculiar to veno-venous cannulation. And it doesn't happen with the Avalon cannula because the Avalon is already set and you have the inflow and the outflow far away from each other, so it's not going to happen. But when you use two separate cannulae, and if the cannulae are close to each other, it's very possible that the cannula draining the blood into the pump can suck the blood coming from the other cannula and bring it back. So essentially, that takes the efficiency of the ECMO out because the oxygenated blood is not going to the patient, it's going back to the pump. And the way you notice it, essentially, first of all, your systemic saturation will be lower. And the second thing, also looking at it, you will see that the two lines have similar color, the same intensity of brightness. That should clue you to a problem with either cannula position or something of this nature. The only time you see this with the Avalon, you remember I told you you put the hole that brings the blood back against the tricuspid valve. If for some reason that cannula shifts and the hole is on the atrial side, it's possible that oxygenated blood can shoot back into the IVC and the SVC. So that's one thing to watch out for. The other syndrome that's peculiar to veno-arterial ECMO peripheral cannulation is the Harlequin syndrome, which is essentially cyanosis of the upper body and well-perfused, well-oxygenated lower body. That happens when we cannulate with a femoral artery and blood is going backwards. And if the patient has very nice cardiac function remaining, then it's possible with very bad lungs that the deoxygenated blood perfuses the coronaries, perfuses the head vessels of the upper extremities. The way to detect it also is by leaving the radial arc line on the right side and sampling the AVGs from that, because that will clue you in. And the solution for this essentially could be either going up on the flow to improve the mixing, or the application of further drainage into the SVC to drain the right ventricle more, so less blood will make it across. It is another trick. Or if all above fail, then switching the arterial inflow to axillary artery, then you have more central perfusion of the oxygenated blood. LV distension is peculiar also to cardiac support. When that happens, usually we need to put a catheter into the left ventricle to just suction the blood out of it to prevent it from distending. Because if the ventricular function is really poor and the heart is not able to eject the blood out, what happens, the pressure inside the chamber will be equal to the arterial pressure. So the coronary perfusion to the muscle goes away, and within minutes the heart will die. So odds are this patient is not going to do well afterwards. So we need to watch out for it and make sure we prevent it. As you see here, this is from the extracorporeal organization report, looking at respiratory support and the complication rate. Look at the adult percentages. All these complications, whether they're mechanical related or patient related, they're substantial, as I was saying. This is the technology that's really labor intensive and with a lot of complications. So we need to watch out for whether failure of the devices, intracerebral bleeding, cannula sites, cardiac tamponade, seizure. This is for respiratory support. Similar percentages are seen for cardiac support. So a lot of care should be paid. A lot of attention should be paid to these. This is the latest graph showing the number of centers in the world reported to ELSO and the number of applications. And you can see in 2014, 6,500 ECMOs were instituted worldwide and reported. And you see the number of centers, the number of cases is rising with the years. So it's becoming a little bit more popular in terms of treatment modality. And this is the latest accumulation of the reported series between the 90s and up to now. And for veno-arterial support, and mostly for cardiogenic shock, as you see. The survival rate to discharge is anywhere between 60% and 14%. And this is consistent, for the reports when you look at everything. But these mostly are reports that are more recent. The latest ELSO report of the total world experience with the outcomes shows essentially for the adult, and this is my area of interest for this talk today, that survival for respiratory support is about 60%, for cardiac support is about 40%, for emergency department cannulation is about 30%, with a total survival of 60% to discharge, that is. So in general, are the results perfect? They really aren't. But are they horrible or laughable, as someone mentioned it the other day? They're not. They're good, because this subset of patients will probably have close to 100% mortality if this modality is not applied. So in general, we are salvaging some patients. And the best estimate that I've seen was essentially looking at the survival reported results for V-A ECMO support. If you treat 3.3 patients, you're saving one life. And for the V-V ECMO, if you treat 2.5 patients, you're saving one life. These are not insignificant points. So there is value in it. But what are the lessons that we can learn from the past? I can reflect, being an assist device person and dealing with heart failure. I can apply what we learned from the assist devices over the last 15 years to ECMO concept. We learned that the assist devices work. They produce some improvement in outcome. However, they're not perfect. So we learned that by selecting the proper patients, having team approach, a pulmonologist, a critical care physician, a surgeon, an interventional cardiologist, with nurses and pharmacy and so on, having the team approach for selection and execution makes a huge difference in terms of the outcome. So proper selection of patients, continued improvement in the technology, and a multidisciplinary team approach to the concept is key, because that's what put us where we are today with the circulatory assist devices. We have a lot of progress we made over the last 10, 15 years, and this could be achieved with ECMO also. And then obviously the postoperative care will be much more improved if we have the multidisciplinary approach. Again, this technology has a lot of challenge. It's a very tough thing. The road is definitely rough and loaded with obstacles. But I can't help but reverse back to every story that has a name and a face and a success story. And I'd like to leave you with one story that sticks in my mind among the many patients we were able to help over the last few years. This lady is a 32-year-old with variable immune deficiency syndrome, presented with end-stage bronchiectasis. And she was sent to us really late. And Lisa knows her a lot better than I do. But essentially, by the time she came to us, she was literally on the verge of intubation. We whisked her very quickly through the workup process, put her on the list. That night, she ended up intubated. And she was on very high vent settings, a lot of infectious complications from the lungs. So we went ahead, and her score was very high, so we got a lung allocated to her from somewhat of an older donor, but by all indication, the lung appeared to be okay. So we took the lung for her, and the lung did not work. In the operating room for the first couple hours, the oxygen was great, and then started dropping. So it got to a point where I didn't feel comfortable leaving the operating room. I put an Avalon catheter into her IJ, I put her on venous support. She looked reasonable. We went upstairs. I was watching her for the next couple of hours. the venous support was not adequate enough. She started having decompensation, severe pulmonary edema, evidence that the right ventricle was not able to push blood through the lungs. Pulmonary vascular resistance went up way high, so I took her back to the operating room, put her on veno-arterial ECMO to support her. She woke up after the intervention, and on the veno-arterial ECMO in a very miserable stage. You walk by her room and you see her sitting down and flipping through a magazine during the day. But meanwhile, what broke our heart for the most part was the fact that her lungs really, really deteriorated a lot after a very brief period of initial improvement. This woman reached death about 6 or 7 times. She had ECMO malfunction. One time we were transporting her to the OR to release a tamponade, and the ECMO circuit broke on the way when it hit the edge of the elevator, with 4 liters of blood flowing out. I literally had to hold things together, and I got totally bathed in blood by the time we got to the OR. She still made it, and we moved on veno-arterial ECMO after we supported her for 21 days, and a lot of whispers in the back of my ears and behind my back were going on that what are we doing here with this experiment? It's crazy. This woman is dying. We got a pair of lungs from Oklahoma City for her, and we transplanted her. And this is her prior to transfer to the rehab center after she healed and sealed. She was here for a long time, needless to say, but this is her a year out when she was working full-time as secretary and leading a normal life. So this kind of sweet story makes every effort worthwhile. Any questions?
What are your thoughts about patients with severe LDS who are under the Missouri protocol, meaning steroids, that undergo ECMO? What do you do with steroids?
Well, essentially, I mean, we try to win them as much as we can. Obviously, the downside from steroids goes